We believe that rather comprehensive support for health through healthcare and health development that might focus on the individual and community might not only be affordable, but might, under certain circumstances, save money, save lives, and improve the quality of life for the individuals we seek to serve. Now, within the region, there is innovation moving in the direction of strengthening these kinds of primary care services. We're going to hear from Hock, professor or associate professor at Singapore General Hospital, about some of the directions of innovation and reorganization taking place in Singapore.
Thank you. Thank you, Professor Maruyama and Professor Inouye. Good afternoon, ladies and gentlemen. I have a big problem on my hands. I have more than 20 slides and a 5-minute video, and I understand I only have 15 minutes, so apologies to the translators. And I hope your name card don't flip a few rounds before I finish. So I'll go right in, and I'll speak rather fast, and I'll skip through certain slides. There's a sort of a repetition. So we are here because of super aging, and it's not just in Japan, it's around the world. This is the aging around the world. Japan leads the world, but they are not alone. Everyone is in the same trend. Singapore is quite near. This is where we are now. This is where we are 2030, 2050. The whole world is aging, and Asia is leading the pack in all the continents. So bad news for everyone. But more importantly is that it's not only we are having more older people, we are running out of younger people who are economically active between the age group of 20 to 64, who should be working in the banks and in the army defending the country and churning out resources to support the old, but they're all declining. Korea, Singapore, Japan again, and we are declining very fast. In the Western countries, they are declining, but they are it's not so drastic. So in our part of the world, within generations, you can feel the effect. And this is Dr. Margaret Chan, Director General of World Health Organization. He gave this speech at our Wonka World Conference recently, and she said that the things have changed completely. And as our co-chair this morning told us, we need, Professor Fukuhara told us, we need a new medicine for the new era. And in new medicine, I think he doesn't mean, and we all know he doesn't mean there's some new drugs that we invent, but we need a new model of delivering care, especially primary care. So WHO also tells us resources are finite. They're running out because of the increased utilization. There's a lot of wastage. As much as 40% of all the money we spend on healthcare is just evaporated, it's just wasted. Every dollar we spend, 40 cents just get thrown away, and we are effectively only using 60 cents. So we really need to be very frugal. We need to think of more effective and efficient way to solve this problem. And no country, no matter how rich, will not be able to afford the healthcare system of the future if we continue with the present state. And this is an article by a very renowned medical writer, Atul Gawande, and he alerted the world to this new phenomenon of a group of people who he referred to as the super utilizers. They just consume disproportionate amount of healthcare resources. So in this part in Camden, he said that 1% of the population is responsible for up to 30% of the utilization of healthcare resources. So if we want to solve the problem, then very naturally we should attend to this group of people. So in Singapore, we are more pragmatic. We are famous for our Singapore Airlines, so we call them frequent flyers. And these are the people who come to our hospitals repeatedly. We are glad that they come, but it means that we are not doing a good job if they keep coming back. So we have programs that we say we must solve the problem of these frequent flyers, and these are the high utilizers of services. And the older population have a greater need of resources that translate to per capita healthcare cost increase. So you can see the line just go crazy after age 55. It just go up and up, right? Regardless of which country you are. Some are worse and some that, yes. So Singapore's challenge, we are the same. This is our population above 65. It keeps going up from 2000, 2015. And by 2030, we're expecting 24% of the population. And as I said, we are running out of young people. 2015, we have 4.8 to 5 working economically active people supporting one person above 65 who should be happily retired. By 2030, it's down to 2 to 1. And no matter how rich we are, we can't afford. It's like cutting down half the working population of the country and still having the same, if not a higher expenditure for healthcare. And more worrying is that I think many of these elderly are living alone. This is the numbers that are living alone. Elderly living alone means they don't have the support and resources. They are socially isolated and they are at high risk of ill health. And this is people who are living alone, elderly, and they are functionally disabled, as we again heard in the opening lecture. And this is a major problem. And that is this end result. Recently, we have this thing hitting the Singapore headlines, hospital facing severe bed crunch. We run out of hospital beds. We have to put patients in the corridors. And this is the innovation in one of these hospitals to cope with this crisis. So many of us are thinking that, okay, the present primary care is not enough, right? We need a new model. And for want of a better word, my co-workers and I think we need the intensive primary care, just like you need intensive care unit for patients with very, very complex medical problems. We need people who need just a higher level of primary care that our present primary care is unable to deliver, right? So back in 2006 in Singapore General Hospital, this is our largest tertiary hospital in Singapore, and where the care is at its most fragmented and silo and lots of problem of integration. So they say, let's have a group of doctors who can do this integration bit. And they look around and say, who are the best people who can do the job? Who is trained in good general medicine? Who is very community-oriented? Who are very sensitive about the need to use resources appropriately? And they said, family medicine. So they invited a group of us to form a department in the hospital, charged with this mission to say, can you help us solve this problem? We need a solution. Also, we started a model. So we created this new model of care, which we sort of borrowed with permission from the United States. It's called a hospitalist. But we believe that you need to do more than just being a hospitalist, which means that you just focus on the care in the hospital. We say you need to do in the hospital and then bringing them back to the community. Your job is not done when the patient leaves the hospital. So we have this adapted hospitalist program that sort of incorporates some of the family medicine principles. But we are very worried because this is a new service. What if we are killing our patients for this new model? So we said, let's be very careful. Let's do a pilot. Let's see how we compare. So we have usual care, and we have a group of patients who get admitted to our service, which we refer to ourselves as a family medicine hospitalist. And you can see that the comorbidities are the same. So we're not gaming the system, diabetes, all the nasty comorbidities that's very prevalent that creates complex needs. They're all about the same. There's no statistical significance in the two groups. And we find that unscheduled readmission is about the same. Hospital mortality, thank goodness, we are just as good. But the very interesting thing is that the length of stay is decreased by up to 1.5 days, which is 1.1 day, which is quite remarkable because the average length of stay in Singapore in acute hospital is about 5.8 days. And that translates to savings because every day in a hospital costs lots of money. Now after that project, we move on to phase 2, which we developed a slew of services aimed at further improving care continuity. We call this an integrated clinical care service. Essentially, is an extension of what we did originally. The inpatient team, comprising family doctors and our multidisciplinary team, will take over the care of patients that we target and consider to be at high risk as the so-called high utilizers. Then after discharge, we do not leave them alone. We admit them after discharge into what we call a virtual ward, where our doctors and our team continue to keep an eye on them, as if they are still in our hospital. So we call them, and sometimes when they run into trouble, we send a transitional home care team out to the hospital. So we do not want them to come back to the emergency room, and the poor emergency room doctor seeing such a complex case will surely panic and admit the patient. So we said, before they decompensate, before they come to our hospital A&E, let's go out and fix the problem for them. So we had this transitional home care team. And we also have a post-acute community hospital, which is affiliated to our hospital, again, where family physicians work. So after discharge, 5.8 days in the acute hospital, different criteria, palliative, rehab, whatever needs you are, but you're not well enough to go home, come to this hospital. It's a very low-cost hospital. It costs only $300 a day, Singapore dollars a day for a general ward bed, compared to an acute hospital, which costs up to $1,000 a day. So this is tremendous cost savings, both for the system as well as for the patients. And we have encouraging results so far. great reduction in length of stay, hospital admissions, ED attendances. But this is not a randomized controlled trial, so there's some significant limitations in the study. But generally, I think the trend is reassuring that there is probably some impact. The final stage we want to go through now, which is next year or so, hopefully this year, and we are in discussion, and the Ministry of Health in Singapore is agreeable to fund us, is to bring this whole concept down to the population. So before they come to a hospital, we put the team out into the community. And this is a community of elderlies at risk. So in Singapore, the country is very well off, but even in Singapore, there are elderly at risk who are socially deprived. They do not have the resources to support them. They're living alone at home, sometimes with significant disability. We say, let's bring the team to the community. So we are experimenting this third phase called the integrated community of care. Okay, so I think I would like to invite my colleagues to tell us, rather than me telling you everything, I put them into a video to tell you what we're actually doing. I think it will be more effective. So I think I should have enough time for this 5-minute video. Welcome to the Department of Family Medicine and Continuing Care. I'm Dr. Kheng, Hock, the head of department. At FMCC, we provide comprehensive and continuing care to our patients from the hospital to the community and back to their home. This video will feature many of my doctors and the interesting things that they do and our commitment to patient-centered care in this hospital.
At SGH, we have opportunities to provide holistic inpatient and post-discharge care for our patients. There are also exciting opportunities for medical education and research. Our integrated clinical care service provides comprehensive inpatient care for our patients who are at high risk of readmission and have complex care needs. We'll review their medical conditions, execute good discharge planning, and integrate them back into the community. This is possible with our multidisciplinary team, our nurses, pharmacists, and social workers. Our nurses will educate patients in disease management, our pharmacists will assist with medication reconciliation, and our social worker will activate social resources for our patients. After our ward round, we'll gather as a team again to discuss about patients who are discharged back in the community. Through regular phone calls, our integrated care nurse will identify problems early, and our doctors will review this patient in our early review clinic and also in their home.
FMCC has been running a transitional home medical care program since 2002. We are unique in the sense that we provide a multidisciplinary care directly to our patients' homes once they're discharged from hospital. In the home setting, we stabilize our patients' subacute and chronic medical conditions, as well as empower them and their caregivers with the necessary skills and knowledge for self-care.
我从医院回家 ，Dr. Tan 护士来看我，来鼓励我。
Bright Vision Hospital is a 318-bedded hospital that provide continuing care and rehabilitation service for patients that requires further rehabilitation and improvement in their ADLs actually after discharge from the restructured hospitals. We try to improve the patients' ADLs and improve their confidence so that they can function as good as possible back in their own home.
FMCC also has a preventive medicine arm. At the Health Assessment Center, well patients are seen for screening for silent disease. Subsequently, they are offered disease education as well as coaching in lifestyle changes. When you are posted to the Health Assessment Center, you will be trained in skill sets to empower patients effectively for lifestyle change, which is the way to go to reduce disease burden and health costs in Singapore. So I'm personally very happy to see many patients who successfully lose weight or reduce cholesterol levels after my encounters with them. Our department has a strong academic medicine record. Most of us hold faculty positions in the SingHealth Family Medicine Residency Program in Duke NUS and Yong Loo Lin Medical Schools, and we also train family physicians under the College of Family Physicians. Like most of my colleagues, I spend a significant amount of time training residents and medical students attached to our department. More importantly, we have a structured training program to train our medical officers to be competent in complex care so that you can be versatile in any family medicine setting in Singapore.
Being an academic family medicine department, FMCC is actively involved in research to improve patient outcomes. We collaborate actively with researchers from the Singapore Clinical Research Institute as well as Duke NUS University. In FMCC, you can look forward to the experienced mentorship when you take on research projects that will improve patient outcomes and shape the way healthcare is delivered in Singapore.
No, of course not. So I was actually lucky enough to work in family medicine, and during this time I found that we're more like one big family. Even our seniors, they get to know us, they take a lot of time out and talk to you, find out what you like, and I think this actually translates down to the junior staff, and we end up being very close. We go out for makan sessions, go out for movies, and we actually celebrate each other's birthdays together.
I came here to Singapore like 5 months ago. My initial apprehension proved to be wrong, and it was later changed to the warmth and collegiality of my colleagues here. They helped me to settle in quickly, and we soon became close friends.
I actually discovered that there's more to family medicine than what everyone thinks. You know, it's not just being in a GP clinic. I think as a young doctor, you don't really realize that. I started in SGH, and then you see patients there and you send them either home or to Bright Vision for rehab. After they stay here for a couple of weeks and they go home, you know, I actually feel really confident that, oh, you're going to make it at home, you're going to be fine, you know. I think that was that was really fulfilling for me.
Family medicine. Okay, thank you very much. I'll take questions later.
And so we begin to see that in the new initiatives there are transformations of systems, morphing of organizations. Earlier we heard there's an emerging discipline. And I'd like to invite the audience who's been listening with great interest to pose questions either to an individual or to the panel at large. Would you like to begin? And please introduce yourself and your nation of origin or your institution.
Ben Kenny, Australia, Monash University. Thank you very much. I'd like to thank all the speakers for a very thought-provoking session. One of the questions I'd like to ask is, earlier today we were challenged by the idea that systems are designed to produce the outcomes they achieved, and that change requires something radical to occur. Perhaps Kheng Hock could start in responding. One of the models of your system is that it's a move. It could be seen as a move of a gradual change away from a very hospital-based system to bringing the hospital into the community, and we're undergoing some degree of transition from a particular system into more community engagement. In my country, it's very similar to what happens in Amanda's country, that similarly generalists are trained in hospitals, then move into the community for later training. I suppose my challenge is, do we really believe that this gradual transition, continual recognition of the traditional medical hierarchy will achieve the changes that we need to bring about if we really are going to upset the apple cart and have a properly focused primary healthcare system that actually achieves the health outcomes for our community? Or are we just going to slowly drift to another position where primary care is seen as the second cousin or the younger sibling?
I will start by responding. So I think what I present is 9 years of very hard work, swimming upstream, fighting a lot of prejudice and preconceived ideas. It's very hard to change people's mindset of what is the pecking order and where are the boxes you are. Now, even within primary care, I get resistance from people in primary care and family medicine. because they feel uncomfortable. They say, why are you in the hospital? Why is a family doctor doing in a hospital? At least in my part of the world, it's very unusual. I think it's quite commonplace in North America. But I think we are now swimming with the current. I mean, the thanks in inverted comma to this aging population. The policymakers are very, very sharp. They are very objective, more objective than healthcare workers. Because healthcare workers, we are trained in a certain field, we have vested interests, we have our own little kingdoms that we want to protect. But the policymakers, on the other hand, are very, very sharp about where am I going to get the resources for the people. And now it's easy because our policymakers, our leaders are always telling us the present model is not sustainable. Almost a day, without a day goes by where they say that this present hospital-centric model is not sustainable. We need to shift care to the community, but I think they don't know how. And I think they look to the healthcare profession to give the answers, but I think we are very reluctant and slow to come forth with the answer. So I think the ball is truly in the court of healthcare professionals. And I think there are many people who are pushing the envelope, but I think it's a sort of an irreversible trend. Short of the population suddenly transform to a younger population, it's a tide that you can't stop. But I think it will be tragic, it will be very painful with a lot of unnecessary pain and shortages of resources and unequal distribution of resources. If we as a healthcare professional do not quickly come up with the changes that are necessary and keep defending the old system. Yeah.
Rather than work one question through several different voices, let's give other opportunities to the floor. To give time to my co-moderator here. But here.
Thank you. Mike Clagg from Johns Hopkins in Baltimore. So it's really encouraged. It was a great session, and it was encouraging to see countries like Singapore and Japan planning for the future. Just a question for Dr. Kheng Hock. So the data you showed seemed to indicate that the length of stay in the hospital is over 5 days. I'm wondering, are there any initiatives in Singapore to reduce that length of stay? Because in the U.S., that would be a very long average length of stay. And that's another way to free up resources.
We are planning to cut down the length of stay. We are thinking of preventing unplanned readmissions, just like everyone else. Our length of stay is longer. I think it's sort of a tradition, but it's creeping down. And the government actually funds programs to say that if you have think of any innovative ways of reducing this length of stay, we're going to reward you. So we have various programs in all the different hospitals trying to do that. And one of the ways they think they can do that is to integrate services. They are integrating acute hospitals with community hospitals that I talk about, and then integrating them back into the community where there are services to support such a patient, so that the doctors in the acute hospital feel very confident that they can actually move the patients out straight back to the community and shorten that length of stay. A lot of the time is when they are stuck in a hospital is because of the lack of social services in the community to support the patient, or in the case of the doctors feeling uncomfortable or not confident that the primary care in the community can take care of the patient, which is why they tend to hold on to the patient longer than they should.
Years ago, the pathologist Rudolf Virchow said that all medicine is politics, and politics is medicine writ large. I think that if you add up the elements of observation that have come forward in this very interesting panel, thank you so much, that you might come to the conclusion that what's at stake is civil society. The equity that and fairness with which we hope to treat and respect the elderly who have given so much, but now whose welfare may be dependent upon 1.4 workers. The long-suffering daughters-in-law, whom we have not heard much about, who in this society put the care responsibilities on their shoulders as they attempt to take care of their parents, especially their mothers, who might end up in poverty and living alone. I think that the Japanese society treasures civil society and will find a way politically to invest in that which is necessary, whether it's information systems or new health workforce training or new models of organization of care, to do what is necessary to do for the elderly as a test almost of the moral core of the Japanese people. So thank you so much for coming to this discussion, and thank you for the presentations you made.
Thank you very much.
丸山先生、乾先生、ご登壇いただきました皆様、ありがとうございました。これにてパネルディスカッションを終了いたします。